Hey everyone, this is Kate Bomar.
Sophia Shear.
Audrey Copeland.
And Corinne Taroso.
And we are discussing case study 1, breastfeeding. So as far as background, our patient's name is Medina Ali. She is a 32-year-old female Somali Bantu refugee living in Clarkston, Georgia. This is her 4th delivery. It was a spontaneous vaginal delivery with no complications, and the infant is healthy and was born at full term. She's now been on the postpartum floor for 24 hours. She is Muslim and wearing traditional dress. She's also a vegetarian. She speaks limited English and is able to answer simple questions. However, there is an interpreter phone at the bedside for more in-depth discussion. She's agreed to exclusively breastfeed during a private conversation with the nurse. However, there seems to be conflict with relatives and friends. There's currently a pretty aggressive relative in the room that's insisting that the baby needs a bottle right now, that the baby's hungry and the mom doesn't have enough milk. Regarding common Somali beliefs, breastfeeding is a cultural norm, but it's also normal for formula supplementation in the early postpartum period due to perceived insufficient milk supply. Colostrum is also perceived as dirty milk and is usually discarded. Another belief is that babies that are not plump are not healthy, and that breast milk during the early postpartum period is not enough to ensure that the baby is getting an adequate supply of nutrients. There's also discomfort with breastfeeding in public.
Considering this background information, we'd like to begin the assessment by asking Mrs. Lee and her guests what makes them feel like the baby is starving. What cues has the baby been giving them that makes them believe this? Once we know the answer to this prompt, we can specifically address these concerns and work toward a solution together. We'd also like to get an idea how the breastfeeding sessions have been going. We'd like to ask her if she's met with a lactation consultant, and if she has, what the lactation consultant has given her for feedback, and if not, then we'd like to observe a feeding ourselves and make sure that the infant achieves a good latch and that there is a successful transfer of colostrum. Then we'd like to get an idea about their beliefs about breastfeeding. We want to be sensitive of Mrs. Ali and her guests and their ideas about breastfeeding. We'd want to take this into consideration so that we can tailor our teaching in this situation while being culturally sensitive. Lastly, we'd like to ask Mrs. Ali about her feedings with her other children. Here, Mrs. Ali would have an opportunity to really reflect on the successes of previous feedings and feel more confident moving forward. These questions would provoke conversation about breastfeeding and would provide us with more information that can help us focus our education. In addition to these questions, we'd also like to go ahead and perform a focused postpartum assessment. Specifically, we'd like to evaluate her breasts and ensure that there are no complications, such as flat or inverted nipples, that would present a barrier to her breastfeeding. Lastly, considering that Mrs. Ali is a refugee, we'd like to ensure that there is no concern for infectious diseases transmissible through breast milk. We would hope that these concerns have already been performed, but we would want to review them just to make sure breastfeeding is safe.
In patient teaching with Mrs. Ali, we'd start by discussing colostrum. We would teach Mrs. Ali about colostrum and how to express it. This teaching would focus on the content of colostrum, explaining that it is very thick with important nutrients. We would avoid terms like nutrient dense because those may be more difficult to translate over the phone, and instead use simple terms explaining that it is nutritious, important, thick, things that are more easily translated. Moreover, I would like to tell her that colostrum did not begin production until after delivery of the placenta with lactogenesis 2. Again, we wouldn't actually use the term lactogenesis, but it would be important to tell her this because she's concerned about the staleness or oldness of her milk, so this may reassure her that colostrum is safe to give to the infant. Once we've explained the importance of colostrum, I would show her how to express it by hand. Doing this method, we could take colostrum and put it into a syringe where she could see the exact contents of what she was providing her baby. Comparing that to an example of how large the infant's stomach is, she may understand better how colostrum is able to fulfill the hunger of her infant. I would finish that teaching by describing how breast milk changes over time to accommodate the needs of her specific infant. I may even show her pictures of how milk looks different early in an infant's life versus later in an infant's life, and explain that in both scenarios, breast milk is specifically designed so that her infant can grow safely and happily. I would do all of this teaching as much as possible with the relatives present because she comes from a very communal society where others have strong opinions would also benefit from understanding so that they can reinforce this with her when she leaves the hospital. Following the teaching about colostrum and breast milk, I would discuss hunger cues and satiation, specifically talking about how infants show that they're hungry. I would use examples like the pictures on this slide to show how rooting or looking for a nipple or sucking a thumb could be a sign of hunger, and would use this to show her early signs versus middle signs versus late signs where that infant really needs to be fed and comforted. I would also explain that she can expect to breastfeed 8 to 12 times per day, but the focus shouldn't be on timing these with a specific amount of time in between because babies often cluster feed or feed many times at once and then take a little bit of a longer break. I'd explain this purely to reassure her and also reassure her that it's okay if the baby goes a little bit longer in between as long as she is paying attention to the cues of the infant. As further reassurance, I would explain to her how the appropriate number of wet and dirty diapers. For a 24-hour infant, we're looking for 1 wet and 1 dirty diaper. As the baby grows, we'll be looking for more and more wet and dirty diapers. I would explain to her how this changes over time in the same way that the breast milk changes over time, and how she can use this to reassure herself and her relatives that breastfeeding is successful because they're getting the outcome that they're looking for in wet and dirty diapers. As part of this, I would also put the emphasis on the number of diapers the infant has instead of on the weight gain of the infant because she and her relatives are extremely concerned about weight gain. So I would want to take the focus off of that because we don't want too much of the focus to be on weight gain because excessive weight gain could lead to problems in the child's life as a child or as an adult with obesity. And so taking the emphasis off of that and explaining diapers instead and looking at a more short-term way of identifying if the baby's fed may be helpful for her and for her family. Finally, I would discuss safe pumping and storing of milk. Some environmental or cultural barriers to breastfeeding for her may be breastfeeding in public. Since she is traditional, she may not be comfortable breastfeeding if she's in the community at the grocery store or something of that sort that the baby is hungry. So I would describe to her how to properly store milk so that she can give her baby it through a bottle if necessary when she's not able to breastfeed because of cultural or environmental barriers. At the end of all this teaching, I would ask her if she has any questions, and I would again include her relatives and family members in this, allowing them to give insight or ask questions of their own.
Okay, so in looking at the evaluation from teaching Miss Ali, I think first and foremost, and I think Corinne did a great job touching on this, but is ensuring that Mrs. Ali just feels valued and respected and that she understands the teaching. So in the case study, it had mentioned that she was able to answer simple yes and no questions without the use of an interpreter. But since we're really getting into not only kind of in-depth instructions, but also understanding more values and understanding, it would be very important to use the interpreter in this situation and not relying on family members who are in the room to interpret because some of that might be pre-screened and left out. So really using that interpreter phone. I know my rotation was at DeKalb and I had several instances where we used an interpreter and it seemed to work very, very well. Again, making sure the client feels valued, respected, and heard. I think this is the most important thing when looking at breastfeeding, because it is such a time where a mom and baby can really bond, and it's a very intimate experience for the mother. And so really just making sure we take our time with the situation would be quite important. Also, really integrating the guests and the family into the teaching, making sure that everyone's on the same page about what we've gone through in terms of infant hunger, and knowing when the baby is full. Maybe knowing that, if the baby was crying earlier, and maybe the family members thought that that meant baby was hungry, really reinforcing what some of those specific hunger cues are, because baby could have been crying for a different reason. Maybe kind of asking family members other ways that they think the baby is healthy. We know that we talked about in this culture, people feeling that plump babies are healthy babies. Maybe asking some other questions in terms of, what are some other ways that you view the baby as being healthy, to get more into that value. And then again, with all the specific skills and teachings we've gone over, having Miss Ali demonstrate these back to us. So demonstrate a good latch and a good feed. Having her verbalize to us what her plan is for pumping in certain situations and proper storage of that expressed milk. And then again, just keeping it open for guests asking questions, sharing beliefs. One of the articles that I read for this case study looked at nurses' perceptions of working with people from other cultures, and showing that I think the study was looking at a Somali population and also a Mexican population, and some nurses feeling like they were inadequate in doing teachings with patients, and some of that had to do with just discomfort with approaching other cultures. And so I think it's really important that we take the time to sit in that discomfort and to really learn. We have things to learn from everyone. And so really not looking at as we're teaching them something, but we're looking at everyone just having an open conversation to get the best value for the mom and baby.